Good morning, everyone. It's with great pleasure that I welcome you to our seminar today. So for this day, we have two great speakers. One is going to be our Deputy Chair, Professor Surya V Seshan, and Professor Thangamani Muthukumar.
Thank you, Carmen. Good morning, good afternoon, good evening, and good night to all our colleagues around the globe. I would like to thank GLOMCON as well as the ISN Renal Pathology Working Group for giving us this opportunity to show some of the work and share what we have learned. Next, please. Today, the topic will be on kidney transplantation as one of the earliest solid organ transplants, which is now a treatment of choice for end-stage kidney disease. And this has led to other organ transplantations later on. There are multiple factors that affect the successful transplantation towards improvement in allograft as well as patient survival. And these are the list of some of the factors or most of the factors that could affect. But today we will restrict ourselves to rejection, transplant rejection. Next, please. So, and I think worldwide, we all follow the BAMF schema of to assess allograft rejection when a transplant kidney biopsy is done. And this is the latest classification. The categories and subcategories of antibody-mediated rejection changes, T-cell mediated rejection, and borderline or suspicious acute TCMR. Now, before we embark on revealing some of the surprises that tissue transcriptomics can teach us, I would like to quickly go through 3 typical cases of rejection with a biopsy so that we will have a perspective when our tissue transcriptomics studies are being enumerated. Case 1, this is a 65-year-old woman, end-stage hypertension with deceased donor transplant 3 months ago with thymoglobulin induction, had initially some delayed graft function, but now there is worsening kidney function with the creatinine at 3.2. Donor-specific antigen was negative, and her maintenance therapy was the triple therapy that routinely that is given. Next. When a kidney biopsy was done, it was adequate, and these were the findings that we saw. The glomeruli were fairly preserved. The pathology was in the tubulointerstitium, high-grade tubulitis along with interstitial inflammation, and edema is observed at this point, and no evidence of vascular rejection was noted. And next, please. And this is very typical of what we would see in cell-mediated rejection. Now, this is another picture from the same case, and we also did what are some of the cells that participate in this rejection process. Depending on when you do the biopsy, it's a combination of CD3 T lymphocytes and macrophages that are showing the active tubulitis, the high-grade tubulitis. And surprisingly, we also found natural killer cells, CD56 cells also being at a higher percentage, which is up to about 10 to 12% in here, and very few CD20 B cells. Next, please. So this is a typical example of active cell-mediated rejection, BAMF grade 1B, which is assessed by the degree of tubulitis and extent of the inflammation. Glomeruli were fairly normal, and these are the BAMF gradings, which have been tested and validated clinically over many, many years. So the high-grade tubulitis and interstitial inflammation is depicted here. Next, please. The second case is about a 55-year-old woman with end-stage kidney disease secondary to diabetes and diabetic kidney disease. She received a living related transplant 10 weeks ago with one.